Welcome to the PolicyLab webinar series. I'm Barty Nabet, and I'm a strategist and communications associate at PolicyLab. PolicyLab is a research center within Children's Hospital of Philadelphia's Research Institute. Our mission is to achieve optimal child health and well-being by informing program and policy changes through interdisciplinary research. If you're here with us today, chances are you're interested in learning more about the nearly 200,000 refugee children that have resettled across the United States over the last decade. We welcome our partners from health systems, public health research institutions, and community organizations that are all playing a role in ensuring that refugee children and families do not face disparities in their health and health care. To take us through this issue, we're very excited to have with us today PolicyLab researcher Dr. Katherine Yun and Minnesota Department of Health's Refugee Health Coordinator Blain Mamo. Dr. Yun is a faculty member at PolicyLab, assistant professor of pediatrics at the University of Pennsylvania School of Medicine, and an attending physician in both the Division of General Pediatrics and the Refugee Health Program here at Children's Hospital of Philadelphia. Her previous work has focused on the prevalence of chronic, non-communicable conditions and insurance coverage among refugees in the U.S., as well as differences in primary and dental care utilization by children in different types of immigrant families. We're also happy to have Blain Mamo joining us today. Ms. Mamo oversees the core functions of Minnesota Department of Health's Refugee Health Program, participates in national refugee health organizations and committees, and serves as a consultant in refugee health and research projects across the country. Through her efforts, Minnesota is able to ensure timely health assessment, treatment, and referral for all new refugee arrivals to the state. To kick off National Minority Health Month, we're excited to delve into the issues and clinical solutions that are necessary to better meet the health needs of refugee children and their families. At PolicyLab, this webinar series is just one of the tools we use to translate our research into evidence-based policy solutions at the local, state, and federal levels. For more about us, I invite you to visit our website, subscribe to our newsletter, and follow us on Twitter using the information on the previous slide. Now, before we get started, just a couple housekeeping items. First, feel free to send along your questions throughout the webinar using the Questions tab as shown in the image to the right. We'll do our best to address them during the question and answer portion at the end. Second, we will be showing two short videos as part of the presentation. The audio will be limited to playback only through the computer, meaning you won't be able to hear if you're calling in through your phone. If you can't hear the audio, please don't worry because we'll be posting the webinar on the PolicyLab website and YouTube page over the next few days. You can also revisit the talk or slides at any time there. Finally, over the next couple of days, we'll send out a short 5-minute survey that we kindly ask you to fill out with your feedback for our speakers and ideas you have for future topics in our webinar series. We appreciate you taking the time to answer those questions and look forward to your feedback. With that, I'll turn this over to our speakers. Thank you, and we hope you enjoy the discussion.
Thank you very much for that introduction, Bardia. Hopefully everyone can hear me, and thank you to everyone who has joined us today. We have nearly 500 registered attendees from multiple sectors, including resettlement, public health, state and local government, healthcare, and health insurance. So we'll try to make sure that we use shared terminology and explain terms throughout. Next slide. Blain and I will also try to remember to identify ourselves clearly if we switch off. Right now, this is Katherine Yun from the Children's Hospital of Philadelphia. Along with Bardia, next slide. Along with Bardia, I work at PolicyLab, a multidisciplinary research center within Children's Hospital of Philadelphia. We use data-driven approaches to improve programs, practices, and policies for children and families with an emphasis on children and families at risk for health disparities, including refugees and immigrants. Blain will introduce herself and her work shortly. Our presentation will be about 45 minutes long, followed by time for questions. We hope participants will come away with a deeper understanding of the continuum of care from overseas to arrival in the U.S. for refugees, common models of refugee healthcare in the U.S., how to standardize healthcare for newly arriving refugees, and steps for health systems and partners to ensure the best care for refugees. Blain is going to start with an introduction to her work in Minnesota and an overview of the continuum of care for refugees.
Hello, this is Blain speaking. At the Minnesota Department of Health Refugee Health Program, our mission is to promote and enhance the health and well-being of refugees. Our primary task is coordinating or facilitating the initial health screening for refugees along with our partners, and that usually happens within the first 30 to 90 days of the refugee's arrival in the U.S. Our other core functions include training healthcare providers performing these domestic medical exams to ensure standardized screening across the state, conducting disease surveillance, and using the data to inform our program's activities, which include providing technical assistance and developing educational resources for local, state, and community partners. We also exchange best practices with our local and national partners. Next. The overall context of refugee resettlement in the U.S. should be very familiar to most of you. A refugee is someone who's owing to a well-founded fear of being persecuted for reasons of race, religion, nationality, membership of a particular social group, or political opinion is outside the country of his nationality. This person is forced to flee and is unable to return. Of the world's approximately 65.6 million displaced people, by the end of 2016, there are 22.5 million people formally categorized as refugees. Resettlement in a country like the U.S. is one of the three durable solutions for refugees. The other two are voluntary repatriation and integration into the country of first asylum. Resettlement is the least common of these three options. Since 1975, the U.S. has resettled over 3 million refugees. Next. This group, you all know that refugees arriving in the U.S. are diverse with regards to nationality, ethnicity, religion, and language. Furthermore, refugee arrival groups change significantly over time, reflecting events on the world stage. Next. Regardless of where refugees originate from, before traveling to the U.S., to promote health and healthcare, we need to consider the continuum of healthcare that begins overseas and may cross multiple borders. It starts with health and public health services provided in the family's country of origin, include services overseen by the U.S. government for U.S.-bound refugees, and culminates in the domestic medical exam and integration into primary care in the U.S. Next. In countries of departure where there are refugee camps or urban refugee populations, there is ongoing public health surveillance, and public health surveillance in the country of departure may be conducted by the UNHCR, national and local public health agencies, NGOs that provide health services to refugees, and the physicians who conduct the overseas medical exam. CDC coordinates the overseas partners to monitor surveillance data for communicable diseases. When surveillance identifies a threat to U.S.-bound refugees, CDC and partners work to mitigate risk through public health measures to control disease outbreaks. And if necessary, to reduce the risk of disease importation, refugee departures may even be delayed for individuals and their families until they are no longer at risk. Next. CDC also communicates with state refugee health coordinators to inform us of overseas outbreaks, identify refugees or refugee groups at risk. And then they describe the steps taken overseas and provide recommendations for domestic follow-up if needed. These recommendations are then shared with U.S.-based healthcare providers and resettlement agencies at the local level. Next. Persons with immigrant visas and applying for refugee status in the U.S. are required to undergo the overseas medical exam, which includes a physical and mental examination as part of their visa application process. The purpose of the overseas medical exam is to minimize risk of importing communicable diseases of public health significance. The exam helps to identify the presence or absence of certain disorders that could result in exclusion from the U.S. under the provisions of the Immigration and Nationality Act. The exam is conducted by overseas doctors called panel physicians, appointed by the Department of State and guided by the CDC. Next. Currently, diseases of public health significance include TB, syphilis, gonorrhea, and Hansen's disease, and then any disease designated as quarantinable by presidential executive order or a public health emergency of international concern by the WHO. Next. Additionally, CDC started implementing an overseas vaccination program for U.S.-bound refugees in 2012 to protect health, prevent travel delays due to disease outbreaks, and for children allow more rapid integration into schools after arrival in the U.S. This strategy has been shown to be very cost-effective. Persons with refugee status are now required to get vaccinations during the overseas exam. However, over 70% of refugees entering the U.S. are currently arriving with overseas vaccinations. And we'll show the vaccine schedule on the next slide. Next. The goal of the overseas vaccination is to provide at least 1 to 2 shots of these vaccines listed here. All valid vaccination records, including the documented historical doses and doses provided through the vaccination program for U.S.-bound refugees, are documented on the overseas medical records received by U.S.-based health departments or healthcare providers who are encouraged to evaluate and follow up with necessary vaccinations. Next. As part of the vaccination program for U.S.-bound refugees, all refugees are offered pre-vaccination testing for hepatitis B. And hepatitis B is a viral infection of the liver that can cause liver failure or liver cancer later in life. Next. Overseas testing only includes the hepatitis B surface antigen, which is a marker for chronic infection. Vaccination and testing help prevent long-term complications like liver failure and liver cancer. Next. U.S.-bound refugees are also offered presumptive treatment for parasitic infections, and these treatments are given shortly before departure to reduce the risk of reinfection. Depending on region, departure country, and ethnicity or national origin, refugees may be treated for malaria, schistosomiasis, and soil-transmitted helminths, including strongyloides. Next. And the treatment schedule is available on the CDC's Refugee Health Guidelines website, and one section of the treatment schedule is shown here as an example. Next. Only after completing each of these steps are families ready to travel to the U.S. For the remainder of the webinar, we'll focus most of our attention on the domestic medical exam, or DME, the routine post-arrival medical screening offered to refugees shortly after arrival in the U.S. Next. Most of the people logged on today represent one of these 4 sectors, each of which plays or could play a critical role in the domestic medical exam. Resettlement agencies work very closely with state and local health departments to arrange the health screening for refugees as required by the cooperative agreement with the U.S. Department of State. They're also responsible for assisting refugees with their insurance or refugee medical assistance application. Resettlement agency staff also would assist with various logistical needs, including transportation. The state and local public health systems may work with healthcare providers coordinating the health screening, offering training to providers, and assisting with various disease surveillance activities. They are also the primary entities responsible for collecting health screening and disease surveillance data. Healthcare providers offer culturally and linguistically accessible services and perform complete health screenings and offer follow-ups or refers for routine and complex healthcare needs. Health insurance, including refugee medical assistance, ensure that resources are available to pay for necessary health screening shortly after children and families arrive in the U.S. Now I'll hand things over to Kate, who's going to talk in more detail about models of care for the domestic medical exam and a project we've been a part of that seeks to better standardize implementation of the DME across sites. Next.
So as Blain described, there are multiple sectors that play or could play a critical role in the domestic medical exam, and we'll probably say DME from now on. These cross-sector collaborations are most effective when they're created purposefully with clear roles and communication. Nationally, we've observed multiple models for this kind of collaboration, and because we often receive questions about how a collaboration of this kind should be structured, we'll take a few minutes to describe 3 models that seem to be relatively common. However, we want to acknowledge that these are not the only models available. Additionally, there are many local variations on each of these 3 approaches, and I think many of the listeners are going to recognize their variations in the following slides. So the first model is summarized here, and we've labeled it the screen, refer, and follow-up model. In this approach, the DME is conducted by a single site, such as a public health clinic or federally qualified health center, which is shown in dark blue in the right-hand column. This site coordinates with resettlement agencies, shown in green, and public health partners, shown in pink, to schedule patients, obtain overseas medical information, and collaborate on public health surveillance, such as determining the prevalence of hepatitis B or tuberculosis. However, in this model, this site does not serve as the long-term primary care provider for the patient. Rather, it works with resettlement agencies to transition children and families into long-term primary care after completing DME activities. For more information about this model, the collaboration between Public Health Seattle and King County and the Washington State Department of Health is a great example. Next slide. The second model of care is very creatively called the two-site model. In the two-site model, the DME is purposely split between two healthcare facilities. The first is shown in dark blue on the left side. The second is shown in light blue on the right side. Solid color boxes in the schematic indicate a patient encounter. In this model, the two DME sites coordinate to divide up tasks. Resettlement agencies, shown in green, collaborate with both sites. The first site may complete initial laboratory screening for the DME, often focusing on communicable conditions. The second site may complete additional screening for non-communicable conditions, collaborate on treatment of communicable conditions, and initiate ongoing primary care. This model builds on the strengths and the priorities of the two collaborating healthcare facilities. Reasons for using this model include timing, geography, or access to subspecialty care. Timing matters because the first site may be able to schedule patients within the recommended 30-day window for the DME, but it might lack capacity for ongoing primary care. The second site might have longer wait times for new patients, but may have greater capacity for ongoing primary care once patients are part of that system. Location matters if the first site is more difficult for refugee families to reach. The second site may be located more proximately to refugee families' homes or businesses. And access to specialty care might matter for patients with complex chronic conditions like congenital heart disease, just to give an example. For these patients, a second site embedded in a larger healthcare system with multiple subspecialists may improve access to and coordination of those subspecialty services. Note that in this model, as in the prior model, the healthcare system typically contributes to public health surveillance. However, space limitations prevent us from showing this relationship on this slide. Examples of the two-site model include the Lincoln Community Health Center collaboration with Durham County Department of Health in North Carolina, and the Harborview Medical Center New Immigrant Pediatric Clinic collaboration with King County in Washington State. Next slide. The third and final model is the single-site model. In this model, the DME site and the primary care site are within the same institution, shown in dark blue. Again, solid colored boxes represent patient encounters. Green boxes show selected resettlement agency activities, and pink boxes show selected public health activities. In the single-site model, DME-related activities are managed across multiple visits, but all of these visits are with the same provider team. This starts with a pre-visit, which might focus on laboratory testing or might include a mid-level provider visit that includes an overseas medical history and vaccinations. This is followed by a longer encounter for additional screening and treatment and the bulk of the DME. And a third visit is often planned to address ongoing medical issues and integrate the patient into ongoing primary care. Valley Community Health Centers in North Dakota and the Pediatric New American Clinic at the University of Vermont are both examples of this model, as is the Children's Hospital of Philadelphia. Next. Regardless of which model is used, there are inherent challenges to implementing the domestic medical examination. The DME is based on relatively complex guidelines that address the needs of different genders, age groups, and nationalities. It's carried out by a wide range of sites across the U.S. and includes community health, public health, and academic medicine, so ensuring consistency is difficult, particularly for sites with multiple trainees. The fund of knowledge for the DME is also different from routine care, so providers are asked to make decisions about conditions that may be less common in their general practice. And some provider decision-making depends upon data about health and healthcare prior to arrival in the U.S., making the transmission of information across the continuum of care that Blain described particularly important. Next. Implementing the DME correctly is of great importance to our patients. We already know that within the U.S. there are significant racial and ethnic disparities in screening and treatment for conditions for which refugees are at higher risk, such as hepatitis B, and the DME is an opportunity to ensure that refugees have a chance to undergo screening, know their results, and take appropriate steps to protect themselves from long-term complications. For example, liver cancer in the case of hepatitis B. Additionally, the DME is an opportunity to strengthen screening and treatment for conditions of both personal and public health importance, such as tuberculosis. And there's evidence that cross-sector collaboration enhances both screening and treatment completion in that case. Finally, health surveillance conducted as part of the DME allows us to improve care by identifying refugee-specific risks for certain conditions that might otherwise be missed or managed ineffectively. An example is the increased risk of lead poisoning among refugee children from Burma, also called Myanmar. After observing this pattern, health and public health specialists identified both refugee camp-specific risk factors for lead poisoning, as well as risk factors that often continued after families had arrived in the United States. The latter included contamination of a commonly used traditional skin cream. With this knowledge, healthcare providers have been able to adjust their preventive health counseling for refugee families to better prevent and treat lead poisoning in this community. Next. So clearly, getting the DME right requires collaboration across sectors. It also requires healthcare providers to make the right decisions within each patient encounter. However, as we discussed in the prior slides, this can be challenging. The DME guidelines are complex, and they address health conditions that aren't otherwise seen that often by most healthcare providers. One promising approach for strengthening DME activities that take place within the doctor's or nurse's office is to use something called clinical decision support. These are tools integrated into the electronic health record to help healthcare providers adhere to guidelines and other standards of care. The field of refugee health already has some experience using clinical decision support to improve care. For example, Minnesota Health Partners has a prompt for hepatitis B screening built into their EHR. EHR is an abbreviation for electronic health record. These tools can improve public health surveillance by standardizing data collection. Ideally, they should also improve the patient experience. Next slide. Previously, however, most clinical decision support tools for the DME had been developed institution by institution, and they've been difficult to share. This duplication of work is inefficient, as developing new clinical decision support tools requires a significant investment of time and effort, and new DME sites have to start from the ground up. To address this gap, we've been working with colleagues in Minnesota to create a set of DME-focused clinical decision support tools that can be shared by multiple institutions. We want these tools to be evidence-based, guideline-directed, and readily implemented by different healthcare facilities, meaning flexible enough to be adapted to local workflows and local resources. This initiative started with a refugee health professional survey launched by Blain's team in 2016. 603 people responded, from which there were 414 completed surveys by 316 clinicians and 98 other health or public health professionals from 40 different states. From this survey, we learned that an electronic health record system called EPIC was used most often for the DME. We then invited refugee health professionals who use EPIC, as well as state refugee health coordinators, to participate in a consultation process to develop draft clinical decision support tools. Over the course of about a year, more than 21 individuals from over 13 different institutions shared their workflows and clinical decision tools and provided input on priorities and design choices. We used their shared expertise and a careful review of existing CDC guidelines to draft new clinical decision support tools. These were initially piloted at the Children's Hospital of Philadelphia, and we're now in the process of a second pilot with Minnesota Health Partners. The work group members have been incredibly generous with their time and expertise, and I just want to make sure that they receive credit for things that have gone well with this project, and blame for any errors or design choices that folks don't like should lie with our core team. Next slide. The clinical decision support tools for the DME are optimized for the pre-visit and the DME, outlined in pink, for both the two-site and the single-site models. Others have already created excellent tools for the screen, refer, and follow-up model, and so we focused on the other two. The clinical decision support tools guide healthcare providers through the things they should order, meaning medications, lab tests, and vaccines, as well as things they should document, meaning the overseas medical exam data, patient medical history, test results, and patient diagnoses. Next. To make this more concrete, we're going to show 2 3-minute audio-video overviews, and this is where the computer audio becomes very important. But if you don't have the computer audio, please go ahead and you can still watch the video play. The first will show the pre-visit tools for a 5-year-old child named Amir. Amir is not a real child, and this is a stock photo. But imagine a 5-year-old boy recently arrived from Iraq via Jordan. Sorry, next slide. The second video is going to show the DME tools for a 28-year-old woman originally from Bhutan. Again, this is not a real person, and this is just a stock photo.
So to start off our demonstration, we're going to use a patient call center test, who's a 5-year-old male. As you might guess from the name, this is not a real patient, and none of the information that we're going to enter pertains to any real patients either. The clinician would start by typing refugee here, and they would pick the pre-visit smart set. We're going to focus on the pre-visit for our child patient. When we open up this smart set, we can see a couple different fields. The first one is actually a hyperlink to a CDC website, and this is where you could download the child's overseas medical examination information if you hadn't already. Below this, you have 2 documentation fields, one that you would use if you had the OME in front of you, and one you would use if you did not. If we take a look at the OME data entry fields, you can see that the abstract is structured very similarly to the actual OME documentation. You can go through the child's origin, the date of the OME, the location of the OME, and for our purposes, whether or not they have any class A or B conditions. And let's imagine that this is a child with LTBI, or latent tuberculosis. We would know that because we might have some some TB screening information from their overseas medical examination. And that would usually be in the form of tuberculin skin tests or an IGRA. And in this case, let's imagine that this child's IGRA is positive, and we have a reminder to add that to their problem list. We also have their hepatitis testing, whether they had syphilis testing, whether they were treated overseas for any soil-transmitted helminths or other parasitic infections, a prompt to remind you to abstract their immunizations, a prompt to remind you to abstract their vital signs, which is extremely important for children so we can get an accurate assessment of their growth, as well as some other helpful prompts to get their migration history, their physical exam, and to document all of the effort that you've put into this kind of care coordination. And we aren't going to preview everything today, but of course, if you're interested, you can follow up with us. Following the OME documentation, we have some standing laboratory orders. These are consistent with existing guidelines. We also have labs that are done by CHOP because that's our local practice and our local preference, and this could be customized for other sites. Below this, we have a set of modules that are condition specific. And so if you had, for example, a child who had a positive tuberculin skin test or a positive IGRA, but you believe that they were asymptomatic, you would have prompts here for the orders for their chest x-ray and, if necessary, their hepatic or liver function screens. Below this, we have some additional modules. We also have suggested diagnoses and a suggested level of service, but we are not going to go into these in depth today. So for an adult example, we're going to be looking at the chart of attending 1 test MD. Again, hopefully you can tell from the name that this is a test patient, and we are going to be using fake patient information on a fake patient chart. As with the child, you would type in refugee, but in this case, we're going to open the actual DME templates themselves. And so here we have a very similar looking screen, but we have slightly different tools. We have instructions for the refugee domestic medical exam that you could link to via the CDC website. And we have the DME documentation itself. This is a structured form that takes you through the patient's background and history, their concerns for the day, a reminder to abstract the OME if you haven't already, some pre-arrival history that you might have already completed, but if you haven't, you could complete it now, medical history, surgical history, And then standard fields you would expect, for example, allergies, vaccine history. It looks like this patient has a robust vaccine history. Family medical history, health maintenance, review of systems, which you can see here is quite refugee specific, a physical examination, and finally a structured assessment. And you can see that the structured assessment actually parallels the recommendations from the Association of State Refugee Health Coordinators data dictionary. And all of these would help to ensure that you can do some standardized data queries later on if you needed to for your patients. We also have some modules for the domestic medical examination itself. We can compare and contrast the tuberculosis module for the DME to the prior TB module for the pre-visit. And you can see that in this case, we have more extensive information, because in this encounter, you might have already, for example, obtained an X-ray at the time of the pre-visit, and so you might be ready to move on to ordering treatment for LTBI or ordering additional screening or additional referrals. We have a number of modules, including ones for antiparasitic treatment and testing, asymptomatic eosinophilia, hyperreactive malaria splenomegaly, nutrition, and here we have the adult-specific common nutritional supplements used locally. These can be customized for your site. STI evaluation and treatment. And finally, again, we have diagnoses, patient instructions, and a recommended level of service.
All right. So right now, these tools are still being piloted, but drafts are available to EPIC users via an online resource called the EPIC Community Library, and the URL is here. We are also piloting a build guide, which is like a cookbook for integrating these tools into the version of EPIC used at any given clinical site. We're happy, and you can see a little snapshot of the build guide's table of contents in the figure on the right side. We're happy to share the build guide in draft form, and we'll be offering a more detailed look at the North American Refugee Health Conference in June. We're also able to provide technical assistance for sites interested in adopting these tools through at least September of this year. In addition, folks who are using electronic health records other than EPIC should be able to take the build guide and use it to start templating similar clinical decision support tools for their electronic health record. Next slide. In summary, refugee healthcare exists across a continuum of care that begins overseas and continues after arrival in the U.S. While there are different models for coordinating refugee healthcare in the U.S., successful existing models incorporate cross-sector collaboration and integration of overseas health information, and we hope we've shown you a few different ways that this collaboration can be structured successfully. And finally, we hope that we've given you additional ideas for how to share resources and tools for the DME using clinical decision support. Next slide. Finally, we'd be remiss not to end our presentation with an acknowledgement that improving the DME is just one facet of addressing health and well-being for refugee families. You all know that there are other important domains for ongoing work. This includes, but is not limited to, better implementation of medical interpretation and translation services, continuing to build capacity within the broader health system to ensure that services outside of immigrant-specific clinics are accessible to refugee families, continuing to build capacity within refugee communities and nonprofit organizations to ensure that newly arrived families learn to navigate the U.S. health system, ensuring that refugee families remain eligible for health insurance, and addressing other social determinants of health, including nutrition, housing, employment, and education. We hope to continue this conversation and others during the North American Refugee Health Conference in Portland. So next slide, we have included a resource slide for your records. Many of the participants have helped to create these resources, so they probably look familiar to you. And we want to be sure, next slide, we want to be sure to acknowledge the many individuals who have generously contributed their time and expertise to developing clinical decision support tools and understanding these workflows. And we want to acknowledge the clinical decision support team and the Centers of Excellence in Refugee Health. Next slide. So we now have about 15 minutes for questions, and we'll start with questions that participants submitted during the presentation. please continue to share questions using that questions tab or ask follow-up questions because we'll be keeping an eye on that. And I'm going to be moderating, so I will be sharing questions with Blain. Okay. So the first one is a very practical, very important question, which is who is in charge of data entry for clinical decision support tools? And the answer is that it depends on local practice. There are places that are using mid-level providers or medical assistants or secretaries to do data entry, for example, to make sure all the overseas medical exam information ends up in the domestic record. But there are also places where the primary provider, be they a nurse practitioner or a clinician, is involved in data entry. I don't specifically know of any sites where there's a partner outside of the health system who's doing data entry, largely because access to the electronic health record is usually restricted for privacy reasons. Blain, is there anything that you would want to add in for that question?
No, I think that's what happens here locally as well. The providers review the overseas medical records and input the relevant information in their EHR.
Okay. The next question is a more general question. And I think this is for probably Blain for you to start. What are some of the most common issues for partners, be they the health system, resettlement agencies, public health, et cetera, as they try to implement any of these models of care?
I can give you sort of the public health perspective and how we do it here. We always say that the conversations need to start early to get to know all partners, identify workflow and roles for each partner, and also identify potential barriers, including information flow that could be addressed collaboratively. And we always say to always revisit like these conversations because staffing turnovers are high. There are a lot of system and funding changes, so it's always good to revisit the processes.
Yeah, I think that actually reflects the clinical perspective as well, having the conversation early. And I will say I cannot take credit for building any of these models of care. I've always been lucky enough to enter a system where others have done that work before me. But what I've observed is that the folks who've had a lot of success in building a system have really tried to look at it from the perspective of all partners and to understand the win-win for everyone. That seems to be a common characteristic. Okay. We have a few questions coming in that are a little more healthcare specific, so I will probably tackle these. The first one is, do these clinical decision support tools integrate mental health screening results? And as a related question, do the clinical decision support tools integrate EHR reminders? As of yet, we do not have EHR reminders. And I would have to defer to our Epic build team. I suspect a lot of that depends upon local practice rather than refugee-specific practice, but it's a really interesting question. And then, do the tools integrate mental health screening? So yes, within the DME documentation template, there is a customizable section for mental health screening. We know that different sites are using different mental health screening tools, and so providers would need to edit that template in order to reflect their local screening practices. And if they wanted that to be a queryable field, it could also be a queryable field. But again, that's what we call a customization point in the tools because there is variation in local practice. There's another very healthcare specific question. Oh, a vaccination one. Okay, and this is, our clients seem to be having a lot of trouble understanding immunizations that are needed. Actually, this is more broad than just healthcare. Our clients seem to be having a lot of trouble understanding immunizations that are needed for the green care process, and the civil surgeons have not been very willing to collaborate with us in a way that makes things simpler for the clients. Does anyone have success stories about helping clients successfully navigate the immigration vaccination process? So I think this is a question not just for Blain and I, but probably for our full refugee health community. So my first thought is that this would be a great question to share to the listserv for the North American Society for Refugee Health Providers, because often that is a good place to get multidisciplinary feedback. I will say, though, that as part of this project, some of the sites that really generously shared their workflows with us actually showed that their workflow extended well past integration into primary care. And for some sites, such as the New American programs at the University of Vermont, their workflow goes all the way through the green card medical exam. And so that is actually integrated into their refugee health clinic system. Blain, do you have any other thoughts about
Yeah, another suggestion that I would add to this is for refugees, because they're only required to be up to date on their vaccination for the most part, unless they have a Class A waiver upon arrival. They can always go to their local public health. If the local public health has a medical director on staff, they can sign off on the I-693, and that relationship really works well for refugees, having that relationship with the county.
Excellent. What depression screening and substance abuse screenings do you use with refugees? We have had trouble finding a validated screening short enough to be practical in primary care. Blain, do you want to speak to the Minnesota experience, and then I can share a slightly broader comment?
Sure. So in Minnesota, we're currently piloting a screener that only has 5 questions, and information on that is available on our website, and we could definitely share that with anyone who reaches out to us. As part of the Center of Excellence, too, we're also revising the CDC mental health screening guidelines. I don't know if they're going to include any short version of a screener, but that's something that we're looking at right now.
And then there are other tools that folks are using. One that is commonly used for older teens and adults is the Refugee Health Screener 15, and that's being used both in community settings, for example, by ethnic community-based organizations and resettlement organizations, as well as in healthcare settings. For children, it becomes a little more complicated because there are fewer tools that are short and that are validated and that work for multiple age groups. The National Child Traumatic Stress Network did a review a few years ago. That's quite helpful. There are pediatricians who've been kind of looking at more updated information, and hopefully some of that information will be coming soon, as Blain mentioned. I would also say that the question of finding a validated tool becomes pretty complex once you start working with these really diverse refugee populations, where we have multiple language groups, multiple ethnic groups, and widely varying cultural backgrounds. We have tried, when possible, to work with community members to take tools that are recommended in general primary care and to do a careful translation with adaptation for cultural differences as needed. But a validation study in the technical sense is almost unheard of for many of our patient populations, because in many cases, the number of individuals you would need to recruit for a validation study could be equal to or even exceed the total number of individuals from that language and ethnic group, currently residing in the U.S. within that age range. And so, it is a challenging area. Blain, I have a question that I think is for you. Do you think a tool similar to these clinical decision support tools could be used as a guide for public health professionals working in refugee health programs?
Sure. We're actually developing an web-based interactive tool that sort of mimics this EHR smart set. So we're hoping to test that within the next few months. So we'll send out a message when that's ready.
I have logged onto userweb.epic.com. How do I find your smart set builds on this website? You should be able to look both by institution and also by using literally a keyword search by refugee. And if anyone is having any trouble, please feel free to follow up with us individually, because we're happy to try to address that. Great. So thank you all very much for participating. It looks like we're ending early, which I'm very impressed by, but we are available for follow-up questions. And as Bardia said, we will be sharing the slides and a recording with a follow-up survey via email. So have a wonderful day. Thank you all.